Hello, ladies and gentlemen. Welcome to Triple N Media Cardiology Lectures. I am Dr. NIK NIKAM. In this presentation, we are going to look at coagulation cascade, intrinsic and extrinsic, and then we talk about antiplatelet agents, antithrombin agents, anticoagulants, and much more. So let us begin. In order to understand the mechanism of action of various antiplatelet agents, antithrombin agents, and anticoagulants, we first need to have a basic understanding of the coagulation cascade, how the blood clot formation happens. Once we understand that, we'll be in a much better position to see where these various drugs work and how they interact with the coagulation cascade. There are two main pathways through which there is blood clot formation, namely the intrinsic pathway that is happening from within the body. Then we have an extrinsic pathway. So, for example, if you get a cut, that initiates the extrinsic pathway, which is acted upon by factor 7A, which acts upon factor 10x, and that acts upon thrombin, and thrombin acts upon fibrinogen to convert that into fibrin, and after that we have the fibrin threads which entangle the platelets to create a fresh arterial thrombus. The extrinsic pathway and the intrinsic pathway meet at factor 10, and beyond that they both have a common pathway. Let's look at the intrinsic pathway, which is activated by factor 12A, which acts upon factor 11, and it converts that into factor, it acts on factor 9A, then it acts on factor 10A, and beyond that we have a common pathway. And here are some of the drugs that we use in routine practice. For example, rivaroxaban. I'm going to talk more about the details about each one of these drugs, their dosages and indications, but rivaroxaban predominantly acts on factor 10A. Similarly, we have Demogetran, which acts on 2A, which is thrombin. We have same thing with argatroban, bivalirudin, lipiridin, and deserudin. All these agents act on factor 2A or thrombin. Let's look at it from a little different perspective here in the next slide, where we have activation of the platelets from endothelial damage, which can initiate a clot formation, and here are some of the agents that can act upon the platelets in reducing the platelet aggregation. The most common of which is aspirin, we are all familiar with, which acts on thromboxane A inhibitor. It acts like a thromboxane A inhibitor or a COX inhibitor, thus neutralizing the platelet activation. On the other hand, platelets have various mechanisms by which they can stick to each other. The second mechanism is the P2Y12 receptor, which binds these platelets, and the drugs that act upon those include clopidogrel, prasugrel, ticagrelor, and cangrelor. Among these four, the top three ones are most frequently used, and they are used in patients with coronary artery disease following an intervention or bypass surgery after an acute coronary syndrome. Then we have G2B3A inhibitors, glycoprotein 2B3A inhibitors, which act like antiplatelet agents. They are predominantly used in like an interventional setup, like during cardiac catheterization or immediately following that, if we suspect evidence of a increased blood clot formation or a clot burden in the immediate procedure period. Now, coming back to the intrinsic pathway, we have heparin, which acts at multiple levels, like factor 12A. It inhibits factor 11A, factor 9A. It also acts upon factor 2A. So, heparin has blocking actions at multiple levels compared to rivaroxaban, which predominantly blocks factor 10A. Then we also have bivaleuridine, which blocks the factor 2A or thrombin. The coagulation cascade can be blocked. The platelet aggregation can be blocked by a number of drugs which act upon different receptors or different coagulation agents, thus making the blood thinner, reducing the platelet aggregation, and eventually reducing clot formation in the arterial system. We are talking mostly about the arterial system, even though some of the anti-thrombin drugs can also work on the venous side, which we will talk about. So let's summarize the drugs that are commonly used for cardiovascular patients and see how they fall depending upon what we are dealing with. We'll start with the aspirin, which is an antiplatelet agent which is given in the presence of an acute coronary syndrome or patients who have had coronary intervention or bypass surgery. The dose ranges from 81 to 325 milligrams. If someone is coming with an acute coronary syndrome, you can give a dose ranging from 165 to 325 milligrams. As I said, it blocks the thromboxane A1 receptor. It is used in coronary artery disease, myocardial infarction, post-coronary intervention. The minor side effect of aspirin would be bleeding. Next, we have clopidogrel, which most of you are familiar with the trade name Plavix. The dose is 75 milligrams given once daily. But if you are doing an intervention, you may be giving 600 milligrams of Plavix as a loading dose immediately following coronary intervention. It is a P2Y12 inhibitor. It is most often used in patients who had coronary interventions with stents or balloon angioplasty, coronary artery bypass surgery. A small percentage of these patients may be non-responders, in which case doubling the dose might work in these patients, or if that doesn't work, we have to switch them to a different drug like the Efient or Brilinta. Okay, that brings us to prasugrel or Efient, which is given as a 60 milligram bolus followed by 5 to 10 milligrams orally for patients with coronary stents. If the patient is less than 60 kg, the lower dose is used, and it is recommended to avoid prasugrel in patients who are 75 years or older. Now let's look at ticagrelor, which is also an antiplatelet agent. It goes by the trade name Brilinta. The dose is 90 milligrams daily. It is a P2Y12 inhibitor. Again, it's used in coronary patients with stents. And after 1 year, it is recommended to drop the dosage to 60 milligrams per day. Now let's talk about the DOACs, the anticoagulants used in patients with atrial fibrillation, deep venous thrombosis, or pulmonary embolus in order to prevent recurrent embolic events. So this one works both on the arterial side, like in patients with atrial fibrillation. It also works on the venous side, like deep venous thrombosis or pulmonary embolus. The first drug here is apixaban or Eliquis. The dose is 2.5 to 5 milligrams twice daily. It is a factor 10A inhibitor. It is used in patients with atrial fibrillation, DVT, pulmonary embolism. If the creatinine is greater than 1.5, we need to reduce the dose to 2.5 milligrams twice daily. The next drug is Demogetran or Pradaxa, which is given as a 150 milligram twice daily. It is a thrombin or 2A inhibitor. If the creatinine clearance is between 15 to 30 ml, then the dose has to be reduced to 75 milligrams twice daily. The next drug we have is Zerota, which we are all familiar with. It is given in a dose ranging from 10 to 20 milligrams daily. It is a factor 10A inhibitor, just like the apixaban, and it is given for atrial fibrillation, DVT, and pulmonary embolus. Warfarin is an anticoagulant agent, which, as I told you before, it acts at multiple levels. Not only is it useful in patients with venous thromboembolic conditions, it is useful in patients with atrial flutter or atrial fibrillation. It is also used in patients with mechanical valves following heart surgery. So warfarin has been around for decades. It is a fairly safe drug. The only disadvantage is that we have to monitor their PT and INR on a monthly basis and readjust the dosage, which can range from 2.5 to 15 milligram per day. The PT-INR range that we use for atrial fibrillation or DVT is different from what we use for prosthetic valve. If we are dealing with a patient with a prosthetic valve, you would like to see your PT-INR between 2.5 to 3.5, whereas if you're dealing with the atrial fibrillation or DVT, you may get by with 2 or 2.5 times the normal. An important thing to keep in mind is that these patients are prone for bleeding, especially if they are on other antiplatelet or antithrombin agents. For example, let's take, we have a patient with atrial fibrillation with coronary artery disease who goes for a coronary stent. Then they may not only have to continue with warfarin for atrial fibrillation, they also need to be on aspirin and clopidogrel, in which case we may have to drop the aspirin and just keep them on an antiplatelet agent, namely a P2Y12 inhibitor along with warfarin. So the use of anticoagulation is highly complex. It is highly specific to a given patient with the pre-existing conditions, with comorbid conditions, and it is always important to look through these kind of charts and make a prudent judgment on each and every individual patient. Ladies and gentlemen, we have been talking about the coagulation cascade, antiplatelet agents, antithrombin agents, and much more. Thank you so much for watching this presentation. We have more than 150 lectures on various topics in cardiology, and please do and watch those videos, and please do subscribe to our YouTube channel, and we will see you next time.